Good afternoon, good morning, or good evening from wherever you are listening to us. I'm delighted to introduce the first webinar of the COVID-19 webinar series brought to you by Retina International and sponsored by Novartis. My name is Orla Galvin and I'm the Director of Research Policy with Retina International. And the topic for today's panel discussion is the impact of the COVID-19 pandemic on the aging population, with a particular focus on those living with retinal vision loss and neurological conditions. We are joined today by 4 expert panelists who will provide insight to the impact of COVID-19 and the associated restrictions and lockdown type environments on those living with retinal conditions and neurological conditions. Not only these individuals, but also their families and carers, and the impact that policies and research affecting these populations across the globe has had. In terms of housekeeping and running order for this session, we'll first hear from Keith Gordon, PhD, Senior Research Officer for the Canadian Council for the Blind and Chair of Retina Action. Keith will be followed by Dr. Heather Snyder, Vice President, Medical and Scientific Relations from the Alzheimer's Association. Following Heather, we will hear from Karen Denton, who is the AMD Ambassador for Retina South Africa. And finally, we will hear from Donna Walsh, Chief Executive of the European Federation of Neurological Associations. Once we have heard from each of our panelists, we will then open the Q&A session. If you're listening in and would like to ask our panelists a question, please email registration@retinainternational.org. This is how you would have signed up to listen into this event. If we do not get to your question within time, we will be sure to follow up and get back to you subsequently. So without further ado, I will pass you over to Keith, who is going to speak to us about the impact of COVID-19 on Canadians who are blind, deafblind, and partially sighted.
Thank you very much, Ola. I'm here to basically to set the scene for what a post-COVID world might look like. In order to understand the post-COVID world, it's important to understand what patients have been through during the pandemic. So I'd like to talk to you about a study that we conducted at the Canadian Council of the Blind to look at the impact that the pandemic was having on Canadians who are blind, deafblind, and partially sighted. Next slide, please. Our objective primarily was to look at the impact, but secondarily was to feed this information back to governments at all levels in order to assist them in creating policies to support those living with disabilities during this time of COVID. And we did that, and we had a fair degree of success, some of it on the financial side. The next slide, please. We conducted our survey in the middle of the pandemic, at the height of the pandemic in Canada, which was April the 7th to April the 14th. The survey was conducted online, which made it a little bit biased because it only catered to people who had access to the internet. We did the survey by emailing a number of mailing lists that we had access to. And next slide, please. And we had a very robust response. We had 572 respondents from all provinces across Canada. About 40% were over the age of 65, which is the topic of today's discussion. 37% rated themselves as blind, 60% as partially sighted, and we had a small number of deafblind people as well. 28% of people had one or more additional disabilities, and of significance was that about 28% of respondents were living alone. And that was of great concern during the time of the pandemic. We had only a small response from people living in retirement homes, and I think that's largely due to the fact that we did this survey online. And people in retirement homes don't always have access to computers. Next slide, please. We asked people where they were getting their information about the pandemic from, and not surprisingly, most of them got it from TV, radio, internet, and a variety of social media. It seemed fairly obvious, but it ruled out things like newspapers and other print media as a way to get information to people. We found that 69% of people had accessed government information. Now, those that accessed it via the website said that government websites, about half of them said that government websites were not fully accessible. And about a third said that government websites were only accessible sometimes. Now, this may not actually be the fact, but it's perception, and people were clearly having difficulty accessing government websites. So anything we do in the future about getting information out to people through websites must take into account that those websites need to be accessible to people who have vision loss. We also found that about half of the deafblind community didn't have access to a deafblind interpreter, which makes it almost impossible to access information. Next slide, please. We asked people if they knew where their local COVID-19 testing sites were, and more than half of people were unaware of where it was. That's not surprising because most sighted people didn't know where it was either. But of concern was that people didn't know how they were going to get to a testing site if they had to. About 19% were unaware how they would get there, and about 22% were going to use public transport. So here you have somebody who's coughing their head off, who's going to use public transport, and that's just not acceptable. Next slide, please. We found that almost everyone had left home for one reason or another during the pandemic. Most of them expressed concern about social distancing due to the fact that they couldn't see where the other person was. About half of the people needed a sighted guide when they left home, and at the time, we were being told that you couldn't go anywhere with somebody who's not a family member and stay within the 6 foot guideline or the 2 meter guideline for social distancing. So as a result, about half the people who went out felt unsafe when they left home. If they went out on their own, they were totally unsafe, and if they went with others, they were still concerned. Next slide, please. Next slide, please. Okay. We found that about a third of people were shopping in store for groceries and pharmaceuticals by themselves. And we then asked those that were shopping how they felt about shopping, and they said they were uncomfortable interacting with staff. Staff who were generally not aware that they were blind and wouldn't go out of their way to help. And if they did, they came too close. If they were standing in line, they didn't know if they were at an appropriate distance from the next people. So shopping in person was not an acceptable method of shopping. About a third of people were shopping online for the first time, and about a third were shopping online generally. Not all websites were accessible. And again, there has to be a push going into the future to make sure that all websites that are going to be accessible to people who are shopping online from home have access to accessible websites. Next slide, please. Coming down to the crux of today's discussion, we're looking at healthcare issues. We found that most people were aware that healthcare was being provided in some format online, some of it by telephone, some of it through Zoom conferences and things of that sort. We found that about 3/4 of people were still worried about their ability to see a doctor if they got sick. A third of people didn't know how to arrange a telehealth appointment if the need arose. About a quarter didn't know how they were going to get their prescriptions. And about half people were concerned about having someone accompany them to see a doctor or get to the hospital. Hospitals had said that you could only come into a hospital on your own. Nobody could accompany you, and doctors were very inaccessible at the time we did the study. Next slide, please. About half the people had a personal care worker coming into their home. Now, considering that personal care workers go from house to house and client to client, there's a real concern that if they pick something up from one client, if they picked up COVID from one client, that they would possibly bring it into your home. And so we asked people if they knew whether the folks coming into their home were wearing the proper PPE, and 40% said that they were not. Now that, I think, increased as the value of masks increased over the course of the pandemic, but it's still very concerning that people are going from home to home and aren't wearing the proper PPE. Next slide, please. So the overall impact of the survey resulted in a lot of stress, fear, and apprehension. 90% of people were apprehensive over the well-being of their family. About half of people were concerned that the additional stress of the pandemic might cause them to feel overwhelmed. And then we asked a question asking people to rate their stress level on a scale of 1 to 10. And we found that 40% of respondents said they were experiencing more than moderate stress, with 29% rating their stress level at 7 or higher. So it's almost a third of people having very high stress levels. Next slide, please. We asked an open-ended question asking people just to tell us what concerns they might have, and we discovered a large number of fears. Top of the list was social distancing, which I've already talked about, accessing healthcare. People were afraid that they may get the virus. There was a fear of developing mental health conditions, a fear of feelings of being alone and isolated. There were concerns about their eye condition and fear that they may lose more vision because they wouldn't be seeing a doctor, possibly for their anti-VEGF injections. We discovered that many online learning sites, both for kids and adults, were not all accessible. And discovered that there were people that were afraid of what might happen to their guide dog if they became sick. So that's sort of a secondary thing, but it was a real issue. Next slide, please. So what does it all mean for the future, setting up the discussions that we're about to have? Healthcare in the future needs to take into account that you're dealing with a patient population that has been significantly under stress. They're concerned about access to healthcare. They're concerned about access to information. We found that not all websites are accessible, so any information that's being put out needs to be put out through an online website that is accessible. People are feeling very lonely. They're used to having folks come in. They may live alone, but they usually have friends and family coming in. That hasn't been happening. There are mental health issues that have been evolving and occurring. And people are, again, under stress that are aggravating these mental health issues. And finally, there's concern over missed eye doctor appointments. And they're looking around the world, there are countries that have shown that there's a huge catch-up required for people to catch up with their eye doctor appointments. So that's it for now, and I'll pass that back to you, Orla. Thanks very much.
Thank you, Keith. You definitely provided some striking statistics about the added burden to those living with vision impairment during this time, touching on accessibility, mobility, daily activities, the need to really manage care supports, and also mental health. I'm now going to move on to see what we can learn from Heather to know if the Alzheimer's community has experienced a similar trend. We also know that the Alzheimer's Association is involved in a vast amount of research, and I know that Heather, you can share with us some of what that impact on research activities has been. So I'm going to pass over now to Dr. Heather Snyder.
Wonderful. Well, thank you so much. And thank you to all of you for joining and for having me participate in today's webinar and discussion. I did want to start a little bit in the at the beginning, and I think just because not being sure of the familiarity that everyone may have at the linkage between the eye and some of the work that's going on around the eye as a window into our brain, and in particular that growing research suggests that we can detect changes in our eyes as potentially informing us of what might be some of the brain changes that we also may have, and that relates specifically to Alzheimer's, although there's also been quite a bit of work in Parkinson's disease as well. And this includes both potentially visualizing or seeing the buildup of specific proteins. Perhaps it's measuring changes of specific inflammation within the eye. It might also be changes in the width of the blood vessels and the blood flow within the eye. And so there's a lot of work that's been going on as potentially using these measures or using the eyes as an early or an emerging marker of the biological change that we see associated with Alzheimer's, because ultimately we want to be able to identify an individual that has the brain changes associated with Alzheimer's and intervene at the earliest time point to stop or slow the underlying progression. In the United States, there's over 5 million Americans that are living with Alzheimer's, and globally, there's almost nearly 50 million people that are living with Alzheimer's or another dementia. And maybe just for this audience, it would be worth setting the stage of dementia really is the capturing of all of the causes of the changes in memory, thinking, and reasoning. Alzheimer's is the most common cause of dementia, but there are others: vascular dementia, frontotemporal dementia, Lewy body dementias as well. Next slide. And when we look at, in particular, where we are today, the impact of the pandemic on cognition and people living with dementia, I think it is important to note that while having Alzheimer's or another dementia does not in and of itself necessarily impact your risk, we do know that individuals who are over the age of 65 are certainly, we've seen this, and Keith mentioned this as well, we've seen that this is an increased risk population related to SARS-CoV-2 infection or COVID-19 complications. We also know that many people with dementia are likely to also experience underlying health problems, particularly diabetes or cardiovascular disease. We see an increased association between those health issues and later life dementia. And this may also increase the risk for complications related to COVID-19. And then the other aspect that I think I would just want to mention as we think about dementia is that individuals with dementia may not necessarily remember to wash their hands or put on their mask in the same frequency that might be necessary to help protect them. And there is increasing data that suggests that COVID-19 may also negatively impact the brain and an individual's cognition and function. And we're unclear at this point in time. The data is still being accumulated to look at whether this may be more exacerbated in somebody with dementia. And so there's certainly a lot of work that's going on, and we can talk about that if there's time at the end. Next slide. So I think one of the aspects that we had talked about in sharing on today's webinar is that, and I think Keith really outlined a lot of the issues that many people have expressed or have indicated. But if you're providing care for someone that's living with dementia, it is a challenge to have the reminders in terms of the importance of hygiene, and some tips that could be possible to include would be signs around washing hands with soap for 20 seconds and developing strategies that might do that. I know there's researchers that are looking at technology that might be able to assist and help with that. Continuing to demonstrate thorough hand washing, and of course having hand sanitizer that could be an alternative. If you're providing care and support, and in particular during this time when many people are confined to their homes, it is a challenge, particularly if you were dependent on adult daycare or respite care or other types of support from the community. And so looking at making alternative plans, and I will say the Alzheimer's Association has a 24-hour helpline that you can call to help discuss these types of how to make alternative plans, what might be available in your community, and beyond. And that number is 1-800-272-3900. I would also, other tips for caregivers is ensuring that you request prescriptions for more days and making alternative plans so that if the primary caregiver does become ill, how will you manage that? So making sure that you have some of those steps in place for both yourself if you're the one providing care and for the person that's living with dementia. Next slide. And I will note that if there is rapid confusion that the individual experiences, then contact your healthcare provider, because that is a sign of additional complications. Orla had mentioned at the very beginning that we are, the Alzheimer's Association is a funder of research, and actually we're the world's largest funder of Alzheimer's and dementia science, nonprofit funder of Alzheimer's and dementia science. And one of the things when March happened in the United States, but also all around the world, was we worked very closely with our more than 550 awardees in 31 countries, because many labs were impacted, clinical trials were impacted, really due to concerns around the safety and the ability to have adequate social distancing for the researchers, the trial volunteers, the staff. Many clinical sites were unable to have participants coming into the site. And so that certainly that was quite a challenge. And in fact, we hosted a number of discussions among the scientific community on what were both the challenges, but also the strategies to overcome those challenges, because we need the research to go forward in order to have both tools for early diagnosis and detection, but also treatments and interventions that will ultimately be able to help stop or slow the progression of the disease. And I think some other, interestingly enough, though, is I wouldn't, while that was very staggering, and I think certainly a challenge, there were a lot of opportunities that we also saw emerge. And in fact, the association houses 3 journals in clinical neurology, including Alzheimer's and dementia, which is the top disease-specific journal in clinical neurology, and number 3 overall. And what we actually saw is we saw a significant increase in the papers and the manuscripts being submitted to the journals. Really, as scientists might not be able to be at the bench, they were compiling data and moving the science forward. So we were keeping the momentum of the scientific conversation. There was also, I think, an increased utilization of secondary data analysis, so using data from studies that had been previously going on and looking at and asking questions in a different way. So there's a big data platform that the Alzheimer's Association hosts called GAIN. We certainly saw a steady increase of users and individuals that were looking at how to generate new ideas to take their research forward. And then lastly, I think we saw an increase of scientific meetings moving virtual. We host the largest meeting in dementia science, AAIC, or the Alzheimer's Association's International Conference. And typically we see about 6,000 scientists that come together in a given year. This past year in July, we had over 33,000 participants. So it certainly opened the door to an increased participation from around the globe, from scientists at all levels. We saw an increase in students and others that may typically not be able to travel. So again, that's the silver lining of, while we miss the opportunities of the networking and the collaborations that may happen in the hallways of a conference center and when everyone's in the same place, we certainly had a significantly increased access with 33,000 people from 140 countries that were able to be part of the scientific conversation and move the science forward. Next slide. And so I just wanted to end with a series of tips that are available. And you can get these on our website, those tips for the caregivers or that help to navigate. And again, all of this can be found through our 1-800 helpline. You can see the number here, and there are individuals that are available in multiple languages as well. But this does help, various tips for caregivers to help navigate these current times. In particular, some of the discussion that we shared here as well today. Thank you so much, and I look forward to the discussion.
Thank you, Heather. And I think your message is quite clear. We do need the research to continue to benefit all of our patient populations. It's also quite clear that similar to those living with vision loss, those living with dementia, and those who care for them, face a much, much larger challenge to live safely during this pandemic. And we can touch more on that during our discussion. For now, though, I'm going to move on to Karen Denton. And Karen, as the AMD ambassador in South Africa, can I invite you to share with us the experience of the COVID-19 pandemic on your community, which has some very developed and some underdeveloped regions?
Thank you so much. It really is an honor to be able to give everyone a glimpse of South Africa during the current pandemic. As you've just mentioned, South Africa is a country with great, almost exaggerated diversity. And although a lot of the points that were raised by the previous speakers are very relevant, I'm going to look at things from a slightly different perspective. Next slide, please. First, I would like to point out that we have first and third world people living side by side. And as you can see in the first picture, a typical home would possibly even be within a kilometer or two of the shacks. Next slide. Similarly, shops cater to the first world with adequate, wonderful, imported often provisions, while many second world shops, next picture, are totally inadequate and usually very, very overpriced. And of course, this disparity is also evidenced in our healthcare facility. Next slide, please. Now, 16% of our population has private funding that costs quite a lot of money, but the other 84%, next picture, rely on state hospitals. These hospitals are unable to provide even the most basic essentials often, and you just get very frequently the most rudimentary of services. In addition, diabetes in this country has reached alarming proportions, together with the well-known risks of retinopathy, because even those diagnosed with diabetes don't seek care timeously, and if they do develop visual problems, they don't know what to do or do absolutely nothing. Next slide, please. This has all provided an alarming situation where the global pandemic has shown the disparity in absolutely everything that we have. The disparities that we had before are totally exaggerated. Access to good nutrition and, of course, medical care are completely divided and exaggerated further and further as this continues. But our president immediately imposed very stringent lockdown rules and to curtail the disease. This was great, but the financial impact meant that fewer people can now afford that expensive private medical care, and the burden on our state hospitals grows daily and is becoming quite critical. Next slide. Next slide. Okay. During the lockdown period, we at Retina South Africa seized the opportunity to embark on two very important projects. First of all, we called the people on our database who have retinal disease. And we found that the issues voiced echoed very much what the previous speakers have said. People said that they suffered from loneliness. And as a result, when we phoned them, they often tried to keep us on the phone for 1 to even 2 hours at a time. They found that the loneliness also exacerbated their fear of COVID for themselves and their families. And of course, they were terrified of the financial impact that was happening, with people losing jobs, losing their ability to provide for each other became a real major problem. And they were significantly very afraid to visit their doctors for anti-VEGF. And we were able to liaise with the doctors and to reassure the patients that when they went, they would be cared for in the strictest and most careful way possible. Next slide. We also used the lockdown time to start a major campaign to get fair and equitable treatment for all patients requiring, especially in the beginning, anti-VEGF treatment. We will go on to other treatments once we've crossed this hurdle. For both AMD and retinopathy. We approached the major private medical funders who were very reluctant to provide second-line therapy and only wanted to stick to the very cheapest options available. Luckily, our attempts were relentless and were finally met with tremendous success. And we're very proud that the major funders are now providing adequate and fair treatment for patients with these conditions. We also uncovered an extra problem. Next slide. With the restrictions put in place to deal with COVID-19, we did face a total alcohol ban, and sadly, some people in desperation started to imbibe hand sanitizer. Next picture. And with the disastrous consequences on the optic nerve. As we know, both the types of alcohol found in hand sanitizer destroy the optic nerve and lead to blindness almost immediately. Next slide. But we did find and uncover a couple of positives that we thought we would highlight quickly before we end. First of all, next. People are using cyber connections more and more, and we have found that the more people feel apart, the more they're getting together. We also found that people report that work productivity has increased. They're able to get up and literally start working from the moment they've had their breakfast until late in the afternoon. They don't have to worry about commuting to and from work and spending hours in traffic and all that. We also found that people reported that their shopping costs have decreased. There's minimal impulse buying. They don't have to spend money on petrol and parking, etc., to go back and forth. And that was reported as quite a strong possibility. And people love the increased access to information, learning, and conferences. And we know that most of us were able to attend only 1 to 2 conferences annually. But now we can attend 1 to 2 weekly if we so wish, or even more often. And so on that happy note, thank you.
Thank you, Karen. The disparity of care and service provision you described to us is very, very clear. So congratulations on your successful campaign. And we are aware, you know, even prior to COVID-19, that living with vision loss can in itself be isolating and induce some feelings of anxiety. So of course, COVID-19, we've learned, has indeed amplified this. Coming towards the end of your talk, you mentioned some of the opportunities, and as we move along now to speak to Donna Walsh, Donna, would you be able to take a more global look on the impact of COVID-19 on neurological conditions and explain to us what have been the challenges and opportunities to the communities that you represent?
Thanks, Ola, and thanks to Retina International for inviting me to give the broader neurology perspective to the discussion today. As you've seen, EFNA is a federation or an umbrella of pan-European but also international disease-specific patient groups. So our members would include organisations like the European Parkinson's Disease Association, the Stroke Alliance for Europe, the International Bureau for Epilepsy, and so on. We would also include very common conditions like migraine, but also rare neurological disorders like Huntington's disease, ataxia, dystonia, and of course Retina International are also one of our members. So whilst we don't only focus on the aging population, I think that is obviously a clear demographic that we work with on an ongoing basis. And I think what is interesting is that the challenges that we've seen across our membership really aren't specific to age or to gender, but they are very common regardless of the disease area in question. Next slide, please. So over the course of the summer, we had a number of webinars bringing our membership together to try to think about what were the challenges for our community and to also assess the opportunities or the hooks that COVID was providing us with to take our advocacy forward. And on this slide here, you'll see some of the key challenges that we identified across our membership, across Europe. And a lot of these have already been touched upon by some of the earlier speakers. So interestingly for our community, access to medicines and the medicines shortages that we hear so much about weren't really the biggest issue. It was actually access to services and to supports for our community. So if you think about neurological disorders, they're very often long-term chronic conditions. And the patients in question will often live with comorbidities or multimorbidities. The primary symptoms may not be the most burdensome for the patients. It could be secondary symptoms like pain, fatigue, sleep issues, perhaps the mental health or the mental well-being aspect of living with one of these long-term conditions. And so access to services like neurorehabilitation, pain management centres, psychological support, and so on, really were an issue for our community. So whilst many people could still go and access their medicine, they could go and perhaps access their specialist, it was these add-on services that are so important in an integrated care setting that patients had a real issue with. We also found that patients were really overwhelmed by the amount of information that was being put out there during the pandemic from official sources, but also through social media, through patient organizations, even some of the published papers in very reputable scientific journals during the course of the pandemic eventually had to be taken away because the science just wasn't there in a lot of cases. And it was really difficult, I think, for patients to really understand what is accurate, what is credible, what is reliable, and what is fear-mongering nonsense. And this is something I think we really need to overcome. For patient organizations, you've just heard, there was a huge challenge in terms of balancing the decrease in resources, whether that was financial because they couldn't host their face-to-face fundraising activities or because their sponsorship was down, but also the fact that a lot of patient organizations who employ staff had to let people go even temporarily. So you found that resources were decreased, but on the flip side, the demand for services, the demand for information was going up, and that was a really difficult balancing act for the patient groups. Heather already mentioned the slowing of research and development, the halting of clinical trials, the slowing down of basic research, which in our community is a real concern because within neuroscience, we still don't have cures for almost all neurological disorders, and the treatments that we have really are suboptimal in many cases. So there was a huge concern that research was slowing down, and there is still a concern in the community that when research starts up again and we're back at full tilt, that some of the research prioritized will be focused on communicable or infectious diseases, on coronavirus, and maybe won't return to the sectors that we are very active in. The social impact was also discussed, I think, quite thoroughly on the call already, the isolation that these patients were feeling, even as other people, emerged from lockdown, went back to work, went back to school, suddenly had their social life back up and running again. Some of these patients are still at home and are still afraid to really come outside of the bubbles that they had built for themselves during the pandemic. Carers, you've also heard about already, the fact that external carers or respite care centres had closed down or were not available. And it was the informal carer in the home or the family member who really took on a huge burden. And of course, there's concern now about burnout for those informal carers and also their mental well-being, as well as the mental well-being of the patients themselves. And the last point I think here on this slide is hugely important, that as patient organisations, we've been really pushing for meaningful and systematic patient involvement over a number of years, and that we thought was moving in the right direction. But during the pandemic, this really seemed to die a death. Patient involvement just stopped happening. And we saw a lot of decisions being taken by these national emergency task forces, by our policymakers, by our decision makers, with very little patient involvement. And it had huge indirect consequences, as you've heard from some of our previous speakers, where there was no context to some of the decisions. And what was felt as protecting patients actually was really endangering their health and their well-being. So that is something I think that has been a huge challenge and something we need to address. And we can address, I think, a lot of these challenges, and COVID has provided us with some real opportunities, which I outline on the next slide, if we can move to that. So you'll see here the increased focus on public health. This is really important. I remember back in early 2019 when we were coming up to elections in the European Union, and there was a real concern amongst our organisation and our colleagues that public health just wasn't going to be part of the agenda at an EU level anymore. It seemed that it was losing out to other big topics and socioeconomic considerations. But the pandemic really has put the importance of public health back in the spotlight, and we hope that in the coming years we will be able to really optimise some of the opportunities and the new standalone EU for Health programme that has been created as a means to deal with the fallout from the pandemic, but also to look more to the future and how we can build more resilient health systems here in Europe. The acceleration of the digital transformation, I think, is also probably an opportunity, but it's also a challenge. And you've heard that from Keith and other speakers that, you know, not everybody is digitally literate. Not all digital technologies are accessible. Not every part of the world has the connectivity that we need for these types of applications to really work. But at the same time, if we can really use this digital transformation to do things more effectively, more efficiently, then that is a real opportunity. And this, I think, links up with the point further down the slide where we talk about new models of care delivery and patient pathways. For patients living with chronic long-term diseases, they've been saying to us for years that they don't want to have their care in an acute hospital setting where they need to go and see their specialist for 10 minutes every 3 months, but they would rather be dealt with in a primary care setting, closer to home, supported by multidisciplinary care teams, perhaps with the addition of innovative technological solutions for monitoring and so on. And if we can really use the pandemic as a way to accelerate that shift in healthcare, I think it will be beneficial for everybody. Similarly, we've seen more innovation, more collaboration, more flexibility across the board, whether it's in research or regulation or the reimbursement of new medicines. You know, for years we've been saying the regulations aren't flexible enough. We need more money. We need to do things differently. And always we've had this response that, you know, it's a rigid system. It can't be changed overnight. But what we've seen with COVID is that it can actually be changed overnight. We've seen money coming from bank accounts we were told were dry. We've seen the regulators take a new flexible approach. We've seen companies and other stakeholders starting to work together and to partner and to make these new therapies and potentially the vaccines that might come on stream accessible to everybody. So this is a model that we need to apply across healthcare, particularly in the neurology space where, you know, diseases like multiple sclerosis, Parkinson's disease, Alzheimer's, which we've heard about earlier, you know, these were discovered 200 years ago in some cases, and yet we still have no cure, and yet we still have no treatments for a lot of the symptoms involved in these diseases. So, you know, if we could somehow try and take that sense of urgency we've seen with COVID and apply it to the non-communicable disease space, we might be able to make some really good progress in the right direction. I've also mentioned in terms of challenges that we've really seen that patient and public involvement, you know, just disappeared during the pandemic. But what it also showed us why it's necessary. And this really gives us the impetus, I think, to get ourselves back to the table and to get ourselves involved in the recovery planning. Because it does seem that a lot of our governments and at the European Union level, at the World Health Organization, they're not just thinking how we recover from this pandemic next year, but they're thinking more about how we build the healthcare systems of the future, how we define essential services, how we keep our healthcare systems running when we're trying to work in parallel with a major health emergency. And I think unless we are part of this process now, those infrastructures that are built, you know, really may not be fit for purpose. So it's something that we need to work together on. And what I've found interesting over the course of the last hour or so is that regardless of the disease area, regardless of the country, a lot of us are facing the same challenges and a lot of us have the same perspectives. So I think it's really important that we collaborate, that we partner, and that we work together to really optimize the opportunities that COVID has presented us with. So whilst on the one hand, it's a huge challenge, it's a huge public health emergency, on the other hand, I think it's a real opportunity for change. And I would be interested to hear the comments and the questions that our participants might have on terms of how we can do that. So thank you for having me, and hopefully we'll be able to work further with you to build on these opportunities that I've just outlined.
Thank you, Donna. That was very eloquently explained, the challenges and the opportunities that we face. And indeed, there is a lot of common ground between a lot of the non-communicable disease patient organisation populations. And as you mentioned, we're all covering different disease areas, we're covering different geographical regions, and things that have come through in the question box are relating to essential services. So with one eye on the clock, I might group some of these together. If we talk there about essential services, what is the patient voice? We have heard from governments, and governments are driving the essential services for their own regions. They are deciding, but what is the patient voice? What are the essential services for patients and carers that should remain open? And should medical research, including clinical trials, be considered as essential services? So Keith, I might work through the panel order as we've gone through already. Keith, I'll come to you first.
Well, I'm a little bit biased as a researcher, but I do believe that clinical trials should be regarded as an essential service. Globally, we've spent probably billions on the development of new medications for, in our case, for blindness, but probably for neurological diseases as well. And I think it's essential that these trials continue. And there is a way to see patients in a fashion that's going to protect them from COVID. And I think these trials need to continue.
Absolutely. And Heather, can I ask you the same question? What are the essential services for patient and carers that should remain open? And as a part B, if you like, should medical research, including clinical trials, be considered as essential services?
Yeah, I mean, I think in terms of the resources and services, one of the things that we really worked to do was to transition as much as we could virtually. And so there, I wouldn't say that there was actually a stopping in some of those essential services and resources. It was a challenge. I think there were definitely challenges in that regard. I think Keith had talked a little bit about missed doctor's appointments and those types of things, and that certainly I think continues to be a challenge, especially as many clinics are at reduced capacities and the like. And depending on where you might be in the world, there are also unique restrictions and aspects that might be on play, or that might be at play as well. But many of the aspects around support services or educational programming and some of those, a lot of that has transitioned virtually, which there are certainly challenges with that, and it is not necessarily a solution that works for everybody. So that is where there are, I think telephone and some other strategies, innovative strategies that are being used to ensure the connections and the follow-ups and some of those pieces that continue going forward. And I think I mentioned some of the issues around respite care, adult day centers, but also then visiting in nursing homes and long-term care facilities. And I know that continues to be a challenge and something that is being addressed in a number of different ways, or at least being attempted to being addressed in a number of different ways. In terms of medical research, I think that is obviously the participants and the staff safety is and should be of utmost importance going forward. And I think as we learn more and more, there are strategies that we can employ and put in place. I think one of the challenges will be, or one of the opportunities maybe is a better way of phrasing it, is for the research community broadly, so not just within the dementia research, not just within the retina and the eye research, but across the board, that biomedical research is sharing the strategies that are working, of being able to, what can be done telephonically, or what can be done in other ways, and what needs to be done in the clinic, so that we can both maximize and benefit the participants of the studies as well as the staff, ensuring that we're maintaining safety, all of the necessary protective gear that staff and participants might need, and what are the strategies that really work within your given environment and within your study. I can share, we had a work group earlier this week. This is very specific for cohort studies, where they're community-based, meaning that the staff actually go into the home, and the assessments can be several hours long. And obviously there's a lot of challenges right now with doing that type of assessment, that type of follow-up. So how do you do that, and what do you do? Are there things that you can do, some of it remote or via the telephone, and then you minimize the amount of time in the house? But if you're in the house, what's the type of protective gear? If you have a multi-generational home, how do you ensure that everyone in the home is masked, or what does that look like? And so there's a lot of questions that I'm not sure the research community is we've yet fully overcome, but are really working and sharing with one another what those strategies might be. So certainly seeing that going forward, because I think, as we all have agreed, the research must continue and be able to continue.
Thank you, Heather. And in the interest of time, when I move on to Karen, I might touch on what you've just said, which leads into some of the next questions in terms of perhaps generating diagnoses for somebody. Karen, could I ask you, do you think will delays in diagnosis for conditions for which there is no treatment available yet, will delays in this area have any impact? And is there anything that can be done to support a diagnosis should we encounter a second wave of a virus or have another pandemic?
I think that we've probably learned a tremendous amount from this pandemic that we could apply in the future. And as you know, wherever there is a will, there's a way, and a sensible and well thought out plan for any condition is essential. If I understand your question, are you asking about treatments that are not available for or undiagnosed conditions? Just reword that, it broke up slightly when you spoke.
Of course. Will delays in a diagnosis for a condition for which there is no treatment available have any impact?
Yes, I think that the more one gets involved with any condition, the greater the chance of bringing forward the ability to devise a treatment, the ability of scientists around the world to get together, to share information, and to come up with respected solutions. And therefore, I do feel that any delay is counterproductive, counterintuitive, in fact. And yeah, does that answer what you're asking?
Yes, I think that is so true. Any interaction with any condition that may not have a treatment plan yet may have a care plan, and I think that might be quite true for those living with neurological conditions. So Donna, if I bring that question to you as well, and again, the follow-up question to that is there anything that can be done to support a diagnosis for individuals with neurological conditions should we encounter a second wave of this virus or have another pandemic?
Yeah, so I would agree with what the previous speakers have said, Orla, in that, you know, even if there is no treatment available in terms of a medicine or a pharmaceutical intervention to treat a condition, there is definitely a lot that can be done. And for most of the neurological disorders, you know, the actual medicine itself is only a small part of the ongoing management of the disease. So definitely, I think, you know, people need to be diagnosed. How do you do it during a pandemic? Well, I think, as Heather said, you know, the specialists didn't down tools completely. There are still specialists who are working as and when required, really. There are waiting lists building up at the moment because they're not seeing people who are maybe deemed as non-urgent or non-essential treatment. But I think one of the things that we really need to do is encourage people to seek medical advice if necessary. And this is something that was a real issue for our community during the pandemic. For example, we had a speaker from the European Academy of Neurology on one of our very early webinars who told us that they had a man in his early 50s come into the accident and emergency department at her hospital in France, who had had his third stroke in the space of a week, but had not presented for stroke number 1 or stroke number 2, and only came on the third occasion because he had been so badly hit at that point. But the issue there is that man is going to live with a long-term disability that could have been prevented had he sought help earlier. And the reason he didn't go was because he felt that hospitals weren't seeing patients unless they had COVID. So definitely we need to get the message out there that if you are unwell, you can still see your doctor, even if it's over the phone. You know, they will talk to you, they will triage you, they will see you if needed. And that is something I think that really hasn't filtered down to the patient community. And it is a message we really need to keep putting out there, that if your symptoms are worsening, if you feel that there's something wrong and maybe you haven't got a diagnosis, you need to see a doctor. And we need to get over this. You know, I can't emerge unless, you know, it's COVID. I can't go to the hospital unless it's COVID. And in some countries, there's been really good practice where, you know, certain hospitals have been designated as COVID hospitals and others are to see everybody else. Or there are different streams within individual hospitals whereby, you know, this is the entrance for the COVID patients, this is the entrance for the non-COVID patients. And I think going back to Heather's point, you know, we need to share best practice in terms of how we can do that, just so people don't feel afraid and that they get the help they need when they need it.
Thank you, Donna. That was very, very clear and touched on all of the main key take-home points for today. In the interest of time, I'm going to draw this webinar to a close. I would like to thank all of our panelists, Keith, Heather, Karen, and Donna. I am aware that there has been a request to know how to ask the panelists any questions. So once again, if you would like to send an email via the registration email link, which was registration@retina-international.org, we will be able to pass your questions on and we will get back to you. Thank you very much.